Today we're going to talk about another treatment modality for chronic pain management. Last time I was here we talked about fibromyalgia and kind of the ins and outs and treatment options, and this is one that you can use for fibromyalgia, but it can be used for a lot of other indications. We'll kind of get into that more towards the end of the lecture. But it's Lidocaine Infusion Therapy, and my introduction to this came during fellowship at the University of Utah. This is where I saw it done, and at first I thought, this is a joke. This is just what you do for people when nothing else is working. So if we've tried all the things and nothing's working, let's try a lidocaine infusion. But the longer I was exposed to it, the more I did it, the more it became one of my favorite things because it worked for patients when nothing else was working. No significant disclosures. There's some CME. So we're going to talk about mechanism of action. We're going to take you back to like physiology. We're going to go over a little bit of nerve physiology. We're going to talk about chronic pain, its mechanism of action in chronic pain, disease states. We'll go over local anesthetic, systemic toxicity, contraindications, and patient experience. And my hope is that you walk away from this knowing that there is another option for it. If it's something you're interested in introducing into your clinics, I'd be happy to help you understand how that works and how you can make it work for your clinic. But it's a good option, and it's an there's a lot of need for it. So it's a good option for patients. So local anesthetics can be divided into two categories, okay? I'm taking you back to school here. You've got amides and you've got esters, okay? And the way that I remembered it is that the amides have two I's in it. Okay, so you got lidocaine with two I's, bupivacaine with two I's, ropivacaine. Esters are things like procaine. A little different. Go Utes. Cocaine, also with the U, tetracaine, chloroprocaine. Okay, the amides are what we're using a lot of. Esters have PABA in them, and you're more prone to having like allergic reactions to ester local anesthetics, but amides not so much. They take a little longer to be metabolized. They stick around longer. They're acidic, so if you've ever or recently had a local anesthetic injection, I had a mole removed a couple years ago, and I still remember how much it hurt because injected the lidocaine and it burned. Right? They're acidic, and we'll talk a little bit about why that is. So it burns for a second before it numbs you up, but their ultimate goal is to stop nerve signal transmission. So, all right, back to school again. So if this is a nerve going along here, this is the cytosol inside of the nerve. What happens is you get an action potential, and nerves are constantly being hit by small electrical impulses, but when you get a summation of enough impulses, there's a strong enough impulse, you can get this action potential. Sodium ions will rush inside of the cell, okay, and depolarize that nerve axon, and that depolarization starts this cascade where sodium, you can see, rushes in and continues to rush in and move down the cell. After the sodium rushes in, you get repolarization as potassium rushes out of the cell. So you have a positive ion move in, it depolarizes, and then potassium rushes out to repolarize. You get, for every 2 or 3 sodium that move in, 3 potassium rush out, and then this rebalancing act occurs as active pumps, kind of rebalance the sodium potassium thereafter. And that prevents, as that rebalancing is occurring, the nerve can't fire again because it has to rebalance the sodium and potassium. Here's another depiction of that. But what I wanted to point out here, many nerve cells in our body have these Schwann cell sheaths that wrap around them that form like a myelin sheath, and it allows it to skip. So it doesn't have to happen the whole way along this nerve. It allows it to skip along, and that facilitates faster nerve signal transduction. Any questions about this? I hope you don't, because that's pretty much all I know about nerves. So that's how a nerve works. So what does a local anesthetic do? So you inject a local anesthetic, it burns. It's because it has this hydrogen ion attached to it, right? It's acidic. When it gets inside of you, that hydrogen ion detaches from it, And when it's detached, now it's unionized and it can cross a cell membrane. Can't cross when it's ionized. Crosses the cell membrane, goes inside of the nerve cell, and then in order to work, it has to ionize again. So there's hydrogen ions that it'll pick up, and then it can attach to this sodium channel. And it blocks sodium from being able to move through this channel. So as we saw in the last slide, if sodium can't move in, you're not going to get nerve signal propagation along here. So blocks the sodium channel, and this is a nerve, so you can't get that depolarization, and the nerve can't send a signal. And this is why if you have a patient that has like an infection, and you inject local anesthetic to do a nerve block or to numb them up, where there's an infection, there's often acidosis. And so this environment's already acidic. You're not going to be able to unionize that local anesthetic. So local anesthetic doesn't work super well in an infected part of a patient's body, and that's why. So it's a bit of a process. You lose a hydrogen ion, you gain a hydrogen ion, and then you block the channel. Lidocaine has been used in anesthesia for a long time, whether you're using it to block locally, but even in the operating room, when I was doing OR cases, if someone was having a particularly painful case, I would run a lidocaine infusion on them, a low-grade infusion, just kind of running in the background as they were under general anesthesia, especially for big bariatric cases. So they wake up in less pain, and there's data that shows if you do that, they have earlier discharges from the hospital. There's a less of an opioid burden, and patients just have a little bit less pain. So it's nice, and it works through several mechanisms. That has been, and this isn't a new thing, but they thought maybe we could use it for chronic pain patients in the outpatient setting. And it's been done for decades, just not with a ton of popularity. I think it's mostly for financial reasons. But it has a lot of benefits for patients with chronic pain as well. So not only do you get the immediate pain relief from lidocaine infusion, causing a little bit of pain relief for you overall, but it leads to plasticity of the responses responsible for chronic pain. So maybe I should back up a little bit and tell you a little bit about how I describe this to patients, because I don't go through how a nerve works and all of the mechanisms involved here. But essentially, if you have chronic pain, because of plasticity, your nerves, let's say you have complex regional pain syndrome in your right foot, the nerves that travel from that foot to the brain get really good at sending pain signals. That's what they're doing all day. And even if the original injury gets a lot better, because that pattern has been set up, it's like a rut in the road. That pattern's been set up in your nervous system. You are going to continue to feel really intense pain from that spot that doesn't necessarily match the degree of injury that you have. And it's not just CRPS. It can be any number of injuries. And it's bad, right? Plasticity is great when you need it to learn to do habits. You don't have to think about brushing your teeth because you have this neuroplasticity. But when you have pain, that's a maladaptation. So what we're doing with the lidocaine is, the way I describe it is, when you're having a bug on your computer and you call IT, what do they ask you to do first? Turn it off, right? And turn it back on. That's kind of what we're doing with lidocaine. You do a big infusion of lidocaine and you're turning off a lot of those nerve signals, and then you let it reboot. And what we find often is that patients are getting close to a month of pain relief. Maybe not 100%. In fact, often it's not 100%, but we're often getting 50, 80% pain reduction for 3 to 4 weeks for our patients. So we're just trying to reboot the nervous system. That's the layman's terms for what's going on. This is a little bit more of what is technically going on. But these channels that we're targeting with lidocaine are involved in all types of pain, nociceptive, neuropathic, and inflammatory. Works in the peripheral nerves as well as in the DRG and the dorsal horn of your spinal cord. So it's having effects all the way through that pain pathway system that's maladapted in chronic pain. Targeting the mechanical allodynia and hyperalgesia associated with chronic neuropathic pain. And it can help, in the case of more acute cases, it can help prevent the induction of that central hyperalgesia, or that kind of that developing that pain pathway if you can do it early in patients. Additional infusion benefits are that it can decrease the release and expression of pro-inflammatory mediators. It modulates inflammatory cells, inhibits signaling pathways, and there's indirect effects on central sensitization. So that's the essentially the mechanism. But like I said, I think the easy way to think about it is it's like a hard reboot on your nervous system. So let's talk a little bit about like infusion details. What does it look like for patients? What is it like when rubber meets the road? So patients come in, we encourage them to eat before they come into clinic because, and we'll talk about side effects, but it can help prevent some side effects if they eat beforehand. They come, we place an IV and attach monitors. We're doing continuous pulse oximetry, we're doing a 3-lead EKG, and we're doing blood pressure every 5 minutes. And then I have a nurse monitoring them the whole time. They sit back in a chair that reclines. We turn down the lights and let it run for them. We do it for 30 minutes, and we're going for 500 milligrams of lidocaine over that 30 minutes, which is a big dose of lidocaine. And then we watch them recover, and we send them on their way with the driver, because we don't want anyone getting a DUI. There's usually some slurred speech, and they wouldn't pass a sobriety test. So that's generally what it looks like for them. Here, and there are common side effects. So patients are frequently fatigued. They're just tired during this infusion. Has anyone ever seen a lidocaine infusion here on an awake patient? How about a ketamine infusion? You ever seen a ketamine infusion? Not dissociating like a ketamine infusion, but there is a lot of like fatigue and kind of being out of it. Probably the most common side effect that we see, aside from fatigue though, like that one that patients don't like, because being fatigued is fine, is nausea. We see nausea frequently, and that's one of the reasons we have patients eat before they come in. Usually responds really well to Zofran. Anxiety. Sometimes we see some anxiety in our patients, and we've had a couple like exorcism moments back there. But that's pretty rare, and you can talk patients through it. Usually there's just some anxiety, and I'll tell you why I think that is when we talk about lidocaine toxicity, and I think it's kind of like early stage lidocaine toxicity when they're experiencing that. Emotional lability. So it's very, very frequent that we'll see patients just like cry, and I think some of that is like it's the first time they've experienced pain relief in forever, and there's definitely like a release of emotion and like a grateful feeling that's short-lived. It's just during the infusion. And then flu-like symptoms. I hear that every once in a while from patients that the infusion felt great. I had really good pain relief, but for the next couple of days I had flu-like symptoms, and then it went away, and I felt really great after that. Uncommon side effects. I've had this happen one time, and it was on a patient that had a stroke and had like spastic hemiparesis, and we did a lidocaine infusion, and she had for about a month and a half increased pain, and I felt terrible. But it's out of hundreds that we've done, probably thousands, the only time I've seen that. So it's pretty rare, but I'm very cautious with my post-stroke pain patients to tell them I've seen this happen. I'm happy to do it. It's not a permanent response, but if it happens, I apologize. So those are the common side effects and the uncommon side effects. Local anesthetic systemic toxicity is no joke. Has anyone seen this in the ICU anywhere? So sometimes, yeah, it's no joke. Did it get serious? Did they code or anything?
PACU, they began having significant dysrhythmias, and we had to do a lipid rescue protocol on them.
Yeah, that's serious. Were they intubated at the time?
No, this was post-surgical.
Oh, it was PACU. It's post-surgical.
Yeah, they had a very painful inguinal, I think it was an inguinal hernia, and there was extravasation because we kind of got like almost like a femoral block effect from a lot of local being used in the groin.
Interesting.
And, that's one of the things that made us make the case for Exparel.
Yeah, that must have been a lot, because you'll use like tons when you're doing like liposuction in like the subcutaneous tissue. So interesting. Okay.
One time in 5 years.
Yeah. Well, yeah, and you even got to use Exparel. So the local anesthetic toxicity is no joke. It's real. And lidocaine, so every local anesthetic has its own max dose, right? Because they all kind of have their own different mechanisms, slightly different mechanisms. Lidocaine is, depending on your source, with lidocaine without epinephrine is about 4.5 to 5 milligrams per kilogram. And so, what I told you before is we're going for 500 milligrams of lidocaine in our patients, and if someone weighs 100 kilograms, if our max dose is 4.5, 450 is for a 100 kilogram person, and that's not a small person, all right? A 220 pound person, and we're doing this on little old ladies that aren't even close to 100 kilograms. So we are definitely flirting and often exceeding that maximum dose line, which is why it's really important to have your patients closely monitored with both, technology as well as like an experienced nursing staff. And again, I can get a little bit more into that, but the first thing you'll notice in patients is, so often lidocaine systemic toxicity, you're going to get neurologic effects, and then if it's left untreated, then you'll get cardiovascular effects. So the neurologic effects are nice. There are some non-serious effects that you'll see, starting with slurred speech. And like I said, a lot of our patients are slurring their speech, sound a little bit drunk. Tinnitus, that ringing in your ears, you'll start to see in patients. Paresthesia and lightheadedness, or and often patients will describe numbness around the mouth. Once you get above 10 micrograms per milliliter, you can run into the risk of having a seizure, right, or loss of consciousness. If you keep going, you just let that infusion keep running because you want to see maybe we can get more benefit, and you've had your seizure or through that, then you start depressing people's cardiovascular system, and you can start to have arrhythmias, respiratory arrest, cardiac arrest. So don't push it. Seeing a little bit of this is typically fine, and that's usually where we stop the infusion. These are our early warning signs that we can stop the infusion. And like I said, it's usually the dose to have someone have cardiovascular collapse is much higher than before than the neurologic effects. So about 7.1 times higher than the neurologic effects. So you should see the neurologic effects and stop before anything catastrophic happens to your patients. So if we have minor symptoms, someone's having severe anxiety, or we have loss of consciousness or some abnormal movements, it's not a seizure. We've never had a seizure in I don't know how many we've done, probably thousands at this point. We'll use midazolam, right, a benzodiazepine to treat that, and it calms the central nervous system, because that central nervous system excitability is what they're having right now. For patients that if it were to persist, you got to use intralipid, right? The intralipid therapy, it's an infusion that you give intravenously. At first there's a bolus, and then there's an infusion that you continue. And that binds the local anesthetic in their system so that it stops working at the sites that's giving the patients the issues. Hope to never use this, but if you're going to do it, you got to have the intralipid available. You got to have your staff trained on how to use it. You need to be readily available, you need to be around as a healthcare professional to help run this if you're going to do lidocaine infusion therapy. Another thing to keep in mind is if someone goes into cardiovascular collapse and you're starting a code on them, an important thing to keep in mind is, aside from the intralipid therapy, you're using lower doses of epinephrine. And we're not going to get into why, but just something to keep in mind. Otherwise, you're running kind of standard ACLS protocol. So that's local anesthetic, systemic toxicity. We've talked a little bit about the mechanism. Patients you don't want to do this on are patients that have heart arrhythmias for the reasons that we discussed before. So we screen for heart arrhythmias every time. We're often getting notes from patients' cardiologists. Patients that have seizures, right? It's working on the central nervous system. You can lower their seizure threshold. Pregnant patients, this is my policy. There's not, in what I can find, there's no data that says that lidocaine's harmful for the fetus. The fetus is a sink for lidocaine, but I mean, we're running in patients that are having labor epidurals, we're running local anesthetics. So I think it's probably wise and prudent not to do it on pregnant patients, though nothing that I'm aware of that's like a direct contraindication to it. And then obviously if they have an allergy to lidocaine, we're not going to do it for them. So diseases that we use it to treat, right? Just patients with chronic pain in general. That's why I put that one up there first. Fibromyalgia, it's been wonderful for our fibromyalgia patients. Complex regional pain syndrome, I already brought up. Post-herpetic neuralgia, Ehlers-Danlos syndrome patients with a lot of chronic pain. They have kind of similar mechanisms to fibromyalgia patients. That central sensitization, it works well for them. Post-laminectomy syndrome patients, we have a couple patients where it's been very helpful for them. Chronic migraines. And then the question mark I put up here is just like, I mean, if it's hurt for a long time and we can't do anything else about it, we'll try it. And it's often working. We'll do it, done it for like burning mouth syndrome and all kinds of interesting pain complaints from patients. So we're going to talk, since we're talking about patients that it works for, I'm going to discuss a few patients that it has so you can kind of see it a little bit more in real life. So this gentleman, AE, has cervical radiculopathy. Cessi's work for him. They work really well for his cervical radiculopathy symptoms. He's got lumbar radiculopathy. Lumbar epidural steroid injections work really well for him. He has vertebrogenic back pain, and so he has those modic changes on MRI, and I did an intercept. Worked great for his back pain. He's got fibromyalgia too, right? This guy can't win for losing. And he's still left with like this chronic, just kind of underlying pain all over. And lidocaine infusions have been great for him. He comes in monthly and does his lidocaine infusion, and it's worked really, really well for his chronic pain. And I should bring that up. I don't think I've mentioned that so far. Typically, like I said, it's working for about 3 to 4 weeks, right? So patients are usually coming back in about 4 weeks to do another infusion. I don't do them more frequently than that, but you could, but we do them every 4 weeks. And he's getting about 80% pain reduction for the last one I looked at. It was 2 weeks, but sometimes he's getting 3 or even 4 weeks. We have a few patients that it works for months, and they're coming in every few months to do it. This poor lady stepped in a hole in a parking lot at the Huntsman Cancer Hospital and broke both of her ankles. And she developed complex regional pain syndrome, and she's did lumbar sympathetic block. She's done physical therapy, and with some benefit, but still just really, really struggling from this. And we started lidocaine infusions on her. She's getting 40 to 80% pain relief for between 2 and 4 weeks out of the month. So been great for her. And you can see this isn't the first thing I go to. This is not my favorite therapy for these patients by any stretch, because you're not. I mean, in a month where she only gets 2 weeks of benefit, that stinks, right? And she has to come in every month. She needs a driver to bring her. It's not the most elegant therapy in the world, but when nothing else is working, patients are happy to come in and do it because it's the only thing that works for them. So patient KB, arm, shoulder, and hip pain due to Ehlers-Danlos syndrome. Nothing has really been super helpful for her pain complaints. She's done physical therapy. It's good for her. Physical therapy is good for her. I'm not saying she shouldn't do it, but it hasn't helped her chronic pain as much. She has done. She also has syringomyelia, right? This big syrinx in her spine that's causing this arm and neck pain, and was on Lyrica, oxycodone, NSAIDs, Tylenol when she came in. We started doing lidocaine infusions. She's getting. This is one of our rock stars. She's getting 80 to 100% relief for almost the entire month. Off opioids. Still uses Lyrica. Still uses NSAIDs and Tylenol on occasion as needed. But it's got her off the opioids, and she couldn't be happier about it. And Brad?
Is there a ceiling effect over time where they're getting used to this therapy?
Great question. Not that I have found. And I'll show you a patient here that's is our ceiling patient right now, and we haven't found their ceiling. So
And you're keeping the dosage. You're not increasing the dosage.
not increasing, yeah. When patients come in, and that's another good question that I didn't address. The first infusion is a little bit like, we don't know how much you're going to tolerate. Some patients can get like 250 and they start having those symptoms, so we stop, and that's their max dose. And then we'll adjust it so that they're getting 250 over 30 minutes instead of a 500 milligram per hour or per half hour rate. We're doing 250 per half hour. And that's their dose, and patients that hit their kind of threshold at 250 are getting the same benefit as patients that go for 500 in our experience. Yeah, good question. Patients ask all the time, because you do a steroid injection in someone's knee often enough and the knee continues to deteriorate, and the steroid's not great for the knee either, and eventually the steroid injection in the knee probably doesn't work anymore after a time. That doesn't seem to be the case with this. The lidocaine doesn't hurt any cartilage or pathways necessarily. MP, this guy, cool guy, coach in our community at the high school. He has this weird pain to light touch all around his torso. And the first time he came in, we wanted him to step on the scale. They touched his back to get him on the scale, and he crumpled. He has what looks like could be thoracic radiculopathy, but not all of his symptoms. It's not a clear dermatomal pattern. He responded to a thoracic epidural. We've done all kinds of MRIs, like, is this MS? We don't know what's going on with him. Lidocaine infusions have been super helpful, right? He doesn't have the fear of going out in public, like that someone's gonna touch him out in public. He can go to church, he can work in his yard. He's getting about 50% pain relief for the majority of the month. He's not perfect, but it's helping a lot. And then this is the one I was mentioning, Brad. This is a physician in the community, and she's way smarter than me. She had a distal fibula fracture and went in for repair and got a nerve block, and has developed complex regional pain syndrome. I don't know the whole story, but maybe it was the nerve block wasn't perineural but intraneural or something, but developed CRPS after the nerve block is what it's attributed to, and has done and is doing lumbar sympathetic blocks with Botox with some benefit from that, but not a ton. She's done dorsal root ganglion stimulation with not really having much benefit from that. Physical therapy, TMS. She's done lidocaine infusion. She started, the other place in the state that's doing this right now is the University of Utah. Like I said, where I learned to do it. She did them up there. Her insurance wouldn't cover it being done at the U anymore, so they sent her to my clinic, and we're doing it there, and she gets 60 to 70% reduction of pain for about 3 weeks. Happy to be able to provide that service for her. So that's my last patient experience. That's kind of the end of my presentation. I really appreciate you guys' attention. And what questions do you guys have for me about this?
Just curious, every time you do it, is it about the same dose, or can they handle, do they need as much each time, or is it less and less?
It's the same. It's the same. Sometimes we get patients that are like, I only got 400 the first few times. Can we try for 500? I'm like, you had some symptoms. I don't think we need to. But sometimes we'll try 450 today and see if because they were hoping for. No. Then most people are like, I don't want to go down because it's working. Yeah, good question.
So I often assisted going and being the driver for my wife she's done a large number of ketamine infusions.
Yeah.
So I've seen that reaction and how it's impacted her, but that's a lot more frequent of a visit. And so for this one, over time, I should say, it was more frequent and then it slowly spaced out.
Yeah.
Does that happen with lidocaine infusions as well? Over time, you hope that it's longer than a month?
It would be awesome if it did, but don't see that in practice. Not often. Like I said, we have a few lucky ducks that go 3, 4, 6 months between infusions, but that's the exception, not the norm. Yeah, good question.
Do you have neuromotor side effects with this? So kind of thinking from the activity standpoint or movement standpoint, these people, after they've had it, could they show, decreased proprioception or muscular contraction or other things? Or
right.
Are there indications, so if are you co-treating with PT and chiropractic where we're working together with that? And
great question.
kind of talk about that.
So local anesthetic, lidocaine specifically, they're going to have those effects, but they're very brief. Like patients, often when we finish the infusion, they're just like feeling good, really chill in the chair, slurring their words. But by the time we monitor for 20 to 30 minutes, by the time they leave, they're walking out, still feeling a little off. By the end of that day, they're back to normal. So because it doesn't last very long in your system. It's metabolized pretty rapidly. So that day, they're going to have those side effects. But in the following days and weeks, the hope is, the reason I'm doing this and I cancel all my patients, this is a crutch. I need you to work as hard on your pain as we are, or harder. We need you to be walking. We need you to be doing your physical therapy, your chiropractic, so that we can get better. Yeah, that's my goal for every patient. Like this is just a crutch to get them helping themselves. Yeah.
Do you ever use it for post-procedural pain?
I have, and
I guess let me rephrase my question. Do you ever do it before a procedure to decrease post-procedural pain?
I have not done that. Done it in a procedure, like I said, when I was doing anesthesia. I've done it for a patient that had a knee surgery done actually by Summit Group. They did really, really well, but he's a chronic pain patient, kind of on higher dose opioids, that we were like, we have to do something else besides ramp your opioids. So we did lidocaine infusion on him with some success, not a huge degree of success, but nothing has been super successful for that person, to be honest. So not before. It's not a bad idea. I think you'd need to do it because it's so short. I think you would need to do it right before the surgery probably, and there's going to be local injected for the surgery as well, so it would take a lot of coordination with the surgical team. Not a bad idea.
Additionally, have you ever had any patients that have had trigeminal neuralgia and any effects on that regard?
Yeah, we've done it for trigeminal neuralgia, and doesn't work every time, but probably just overall about 7 out of the 10 patients we try it on are going to continue it because it works well for them. Well enough to go through the hassle of coming in every month to do the infusion. Yeah.
What are the financial implications? You said that it's like covered by insurance.
Yes.
So tell me what that's like for patients.
Yeah, so most insurances will cover it. There's only a couple that won't, and they're kind of smaller insurance panels, so it's a very minority of patients. At the beginning of the year, we do prior auths beforehand, just to see if panels have changed and what they'll do and won't do. But the majority don't require prior auth, we find, every year, and that was my experience at the University of Utah as well. Your patients will have the copay like they do for an office visit, but you can usually. But yeah, it's covered by most insurances. The visit code or the infusion code or both. So it makes it, this is not like, this is not Dr. Brown's retire early plan, but it does help a lot of people, and it's pretty rewarding. Yeah.
I was just going to ask if insurance required failure of other things before they would pay for this.
No, we don't run into that hurdle typically. So it's nice that you can do it and hopefully get them involved in those other things they should be doing too, and maybe with a little more success. Yeah, I think that my time's up, but thank you so much. I really appreciate your attention, and thank you.